I will be discussing renal replacement therapy in the setting of end-stage renal disease. What is renal replacement therapy? It is the life-sustaining therapy that replaces the normal blood filtering function of the kidneys when a person goes into end-stage kidney failure, usually when their estimated glomerular filtration rate is less than 15. Another name for this is dialysis. And dialysis works through the principle of diffusion and ultrafiltration. Two of the most common types of maintenance dialysis is hemodialysis and peritoneal dialysis. During hemodialysis, blood is taken from the body and pushed through a dialyzer machine where it flows across a semi-permeable membrane in the opposite direction of diacylate solution. The concentration of undesired solutes, for example, urea, potassium, and calcium, are high in the blood but low in the diacylate solution. So through the principle of diffusion, solutes move from an area of high concentration to an area of low concentration, allowing for solute concentration equilibrium. For another solute, bicarbonate, dialysis solution level is higher than normal blood levels. This allows for diffusion of bicarb into the blood to neutralize metabolic acidosis that is often present in these patients. Ultrafiltration also takes place through the process of hydrostatic pressure gradient to remove excess blood in order to keep the patient euvolemic. The filtered blood is then returned to the body and the used diacylate is discarded. In order to remove blood from the body, patient will need vascular access. There are two types of long-term accesses, an arteriovenous fistula and an arteriovenous graft. An AV fistula is considered the gold standard access. It is created by surgically connecting a vein to an artery either in the upper arm or forearm. This connection allows for extra pressure and blood flow into the vein, making it big and strong. A large vein allows for easy and reliable access. Without this, regular hemodialysis sessions would not be possible because repeated needle insertions to an untreated vein would cause it to collapse. An AV fistula takes 2 to 3 months to mature before it can be used. An AV graft is a surgically looped plastic tube that connects an artery to a vein. An AV graft takes 2 to 3 weeks to mature but is more likely than an AV fistula to have problems with clotting and infection. A venous catheter is short-term access and commonly used if kidney disease has progressed quickly and the patient doesn't have adequate time for placement of a long-term access. They should be used short-term because they have the highest risk of infection. Hemodialysis is typically performed in a hospital or an outpatient dialysis center, and typical sessions are usually 4 hours long and done 3 to 4 times a week. Typical schedule is a Monday, Wednesday, or Friday, but it is all patient specific and depends on their remaining kidney function, their current weight, amount of waste in the blood, total amount of weight gain in between treatments, and the type of dialyzer used by the facility. Peritoneal dialysis is also a treatment for patients with severe chronic kidney disease. This process uses the patient's peritoneum in the abdomen as a membrane across which fluids and dissolved substances are exchanged from the blood. The fluid is introduced through a permanent tube in the abdomen and flushed out every night while the patient sleeps. This is called automatic peritoneal dialysis. Or the fluid can be flushed out via regular exchanges throughout the day. This is called continuous ambulatory peritoneal dialysis. Peritoneal dialysis is used as an alternative to hemodialysis, though it is far less common in many countries such as the United States. It has comparable risks, but is significantly less costly in most parts of the world, with primary advantage being the ability to undertake treatment without visiting a medical facility. The primary complication of peritoneal dialysis is infection due to the presence of a permanent tube in the abdomen. The most appropriate time to initiate renal replacement therapy remains unknown. There are no universal guidelines to suggest starting dialysis at a specific GFR. The initiation of dialysis is specific to each patient and should be based on their clinical status, their preference, and the expertise of the nephrologist. There have been trends toward early initiation of dialysis, however, studies have failed to show that this improves mortality. The Kidney Disease Outcome Quality Initiative considered the findings of the IDEAL study, which concluded that in patients with stage 5 chronic kidney disease, there was no difference in survival or clinical outcomes between early or late start dialysis. With that being said, they recently updated their guidelines in 2015 to include the following recommendations: that all individuals with a GFR of less than 30 should be referred to a nephrologist so that they can receive adequate education on the various options for maintenance dialysis when the time comes. The decision to initiate dialysis in patients who choose to do so should be based on signs and symptoms of uremia, protein energy wasting, which is a state of hypermetabolism leading to excessive muscle and fat breakdown, as well as if metabolic abnormalities and fluid status is unable to be controlled by medical therapy. Renal replacement therapy should not be based on a single kidney function level in the absence of such symptoms. The purpose of dialysis is to remove unwanted wastes and fluids. It does not replace the endocrine functions of the kidneys. Therefore, patients who receive dialysis will also need to be placed on the following supplementation. Vitamin D is needed for calcium absorption, but when the kidneys are diseased, vitamin D cannot be converted into its active form. Therefore, oral supplementation of active vitamin D will be needed. Erythropoietin is made by kidneys and is required for red blood cell production. IV injections of erythropoietin are given at each hemodialysis session and as an IM injection during peritoneal sessions. Small red blood cells are also lost during hemodialysis, therefore iron is lost with it. IV injections of iron are also given during hemodialysis sessions. When parathyroid hormone levels rise, phosphorus and calcium move from the bone into the bloodstream. So phosphorus binders are used to prevent the body from absorbing phosphorus from the food eaten. Dialysis removes large amounts of water-soluble vitamins such as vitamin B and folic acid, so those too will need to be supplemented. Dialysis patients are prone to leg cramps because of the rapid fluid and electrolyte influx in and out of the cells during each treatment. Vitamin E has been said to help these symptoms. So how should you evaluate a dialysis patient? A complete assessment should include what led to their end-stage renal disease, for example, whether it was hypertension, diabetes, etc., because most likely these chronic conditions still exist. Also ask about what form of dialysis and how long they've been on it. Ask about dialysis schedule, most recent session, prior dialysis complications, and their dry weight. A very important thing to ask is if they still make urine, because some patients on dialysis still have some residual kidney function. If you suspect fluid overload, inquire about recent sodium, potassium, and fluid intake. If the dialysis session was recent, ask how much fluid was removed. One key thing to remember is 1 liter of fluid weighs 1 kilogram, so that will help you estimate how much fluid has been retained or lost based on the patient's dry weight. In peritoneal dialysis patients, it's important to inquire if there has been any change in the color to their diastolic fluid, as this can indicate infection. Physical assessment of renal patients should follow that of any other patient, but pay particular attention to the patient's access location, mental status, heart, lung, and extremities. Consider the clinical situation when evaluating your patient. After dialysis, patients are more likely to be hypovolemic and present with cold, clammy skin, poor skin turgor, tachycardia, and hypotension. On the other hand, patients who have delayed dialysis or missed dialysis sessions will likely be hypervolemic and thus will have signs of fluid overload such as abnormal lung sounds, generalized edema, hypertension, or jugular venous distension. Altered mental status can be difficult to evaluate, but it is an important indicator of serious underlying pathology. Remember that chronic renal failure patient is often also diabetic and may be prone to hypoglycemia, so try to get an AccuCheck as soon as possible. One of the most rare but serious causes of altered mental status in a dialysis patient is dialysis disequilibrium syndrome, better known as DDS. DDS is characterized by neurological symptoms resulting from cerebral edema, which occurs as a consequence of hemodialysis. DDS most often occurs in patients who have just started hemodialysis, although it may also occur in patients who have been under maintenance dialysis for years. It results from urea from the blood being removed more rapidly than the urea from the CSF and brain tissue, thus generating a urea osmotic gradient responsible for moving water into the brain cells. Hyperkalemia is a lethal electrolyte abnormality if it is not corrected on time. Potassium levels are concerning at a level of 6 or greater. However, the urgency of treatment is based on the rapidity of rise, presence of acidosis, and cardiac symptoms. EKG changes warrant treatment immediately. However, normal EKG changes are not reassuring. If there is cardiac involvement, then calcium must be administered immediately. Other ways in which you can bring down potassium level is through insulin and glucose, albuterol, sodium bicarbonate, and or kyaxylate. One thing also to note is that it is important that the blood sample is not hemolyzed, as this can cause falsely elevated potassium levels. Hypocalcemia is also a frequent occurrence in patients with renal failure. It is caused by a decrease in active vitamin D, as well as from aggressive treatment of metabolic acidosis with intravenous sodium bicarbonate. The treatment is to give IV calcium chloride. Mild to moderate hypermagnesemia is frequently found in patients due to decreased renal excretion, but also from increased intake of magnesium-containing products such as laxatives, enemas, and antacids. It is treated with IV calcium gluconate. Hyperphosphatemia is due to decreased renal excretion, and if severe enough, emergency hemodialysis is the treatment of choice. Common cardiovascular complication of dialysis is fluid overload causing pulmonary edema. Emergent hemodialysis is the definitive treatment. However, if the patient still has residual kidney function and makes urine, high-dose Lasix can be started in the emergency department. Nitroglycerin can also be used to bring down the high blood pressure. You should work up chest pain complaints as you would any other patient, but keep in mind that end-stage renal disease patients can have chronically elevated levels of troponin and BUN. However, it should not be attributed solely to end-stage renal disease. Appropriate evaluation and observation are indicated. Dialysis patients can still receive traditional treatment consisting of nitroglycerin, morphine, and aspirin. Infection is a common complication of central venous access. The patient may have common signs of infection as listed above. These infections usually require removal of the catheter, however, others still argue against it. Consult nephrology in this case. Antibiotic coverage, however, should cover for MRSA, gram-positive, and gram-negative bacteria. Usually, AV fistula infections can be salvaged with antibiotics alone. However, AV graft infections usually require surgical excision. Best way to control bleeding at the access site is with pressure and elevation. A Steele syndrome may develop in which the required arterial blood from the distal limb is diverted through the fistula. That extremity develops ischemia. An arterial stenosis or thrombosis can also occur, limiting the supply of oxygenated blood to the distal tissue. The patient may complain of cold extremity, pallor, numbness, weakness, or severe pain. The resultant ischemia can cause permanent nerve damage and tissue damage within hours, and emergent surgical intervention is required. To conclude, I'd like to leave off with a few final pointers. Remember, medication that is excreted via the kidney should be renally adjusted for end-stage renal disease patients. Dialysis patients should be regarded as immunocompromised, and infection is an important cause of death in these individuals. Also remember to never take blood pressure or draw blood from an access arm, as increased pressure will cause damage to the fistula or graft.